Hello everybody, my name's Louise Brown. I work in the translation and education area of Jean Hales, and we're really excited to present our first webinar for health professionals tonight. So thanks for joining us. Firstly, I'd like to start by acknowledging the traditional custodians of the land we're presenting on and the lands we're reaching tonight, and pay respect to elders past and present and future. For those of you who don't know, Jean Hales for Women's Health is a national not-for-profit organisation dedicated to improving the knowledge of women's health at all life stages. We combine research, clinical care and practical education for women and health professionals. So tonight we've had probably about 480 people register for the webinar, which is fantastic. I'm not quite sure how many we've got online tonight. This is our first webinar, so I'm not quite sure how we check those things at the moment. We've had a lot of questions already submitted, and we'll try to make sure these are addressed as part of the case studies, especially the ones that have come up a lot. We may not get to questions in the chat box. We'll do our best, but we will make an effort to provide answers to the questions after the webinar if we miss them tonight. So just keep your eye on our webinar library, and we'll send you a link to that, and the questions will be up there in the coming weeks. We're going to use the chat box if questions are not addressed. You can pop one in there. So if you click on your chat box on the left hand side, maybe just to test it out, and tell us where you are tonight in Australia so we get a sense of where people are watching from. If you've already sent in a question when you registered, don't send it through again, because it's going to be really hard for us to sift through those questions, as I said, because there'll probably be a lot of them coming through, but we'll do our best. So hopefully you've had a chance to have a look at the pre-reading you've received when you registered. I'm going to introduce our experts and ask each of them to give us a few key points about their particular area of focus for the night. And after that, we'll work our way through each of the case studies, and the panelists will all contribute their approach to each of the cases. So we've tried to choose cases that are the kind of things that you'll probably come across in general practice or in your work in the health setting, and some that may be a little bit more unusual, but we'll focus on the ones that you'll probably see more frequently. And the idea is that by using the case studies, we're making this as practical and relevant to your work. But if we don't get to all your questions and we don't cover everything, we might have to start working on a second menopause webinar. We'll see how we go. So first of all, I'd like to introduce Dr. Deirdre Bentley, who's a GP. She trained in, I'm doing an abbreviated version, sorry, of introductions, but if you need more information about each of the speakers, you can have a look in the download section, and their full bios are there. So Deirdre Bentley is working as a GP at Jean Hales for Women's Health in our clinic here. She trained in obstetrics and gynecology in Australia and the UK, and she's worked in family planning clinics and as a surgical assistant in obstetrics, gynecology, urology and general surgery. And she teaches at Monash University Women's Health Program, works in Foster in Victoria in general practice, and as I said, with Jean Hales at the Jean Hales Clinic. Her special interests are menopause, menstrual problems, contraception and pap smears. And tonight she's going to focus on the area of assessment and diagnostics from the point of view of the GP. Thanks, Deirdre.
Thanks, Louise. Menopause presentations gives a really good opportunity to address the whole aspect of a woman, addressing all areas of health, and in terms of what we might think of as a well woman's check. In that we can assess risk factors, address any modifiable issues, and also think about what screening tests and tools might be required. The history, a careful history, really does form the basis of the diagnosis of menopause. And this includes, as in most consultations, assistance review, and in this case including a specific gynecological history, as well as the usual past history, family history, lifestyle factors, social history, and importantly, a mental health assessment. In terms of communication in a menopausal presentation, I think the main things are to follow the old adage of listen, ask, and then listen. And in that you can assess the impact on the quality of life, and the advice that we sometimes give to the partners of menopausal women serves us very well as medical practitioners in being understanding, sympathetic, attentive, tolerant and patient. But above all else, I think these consultations really need you to spend the time assessing all these aspects. The investigations that we will talk about tonight really form in two broad categories. One for any specific presenting problems, but also the screening tests, those that are routine that you might apply to all women, and those that are patient specific based on her own specific history, etc. And then finally, when to refer. And a few broad categories are, well, when the situation is really beyond your scope of practice or expertise, when what you have done isn't working or hasn't worked, and finally, when you don't have the time to spend assessing those completely.
Deirdre. Now we're going to move on to hear from Dr. Elizabeth Farrell. Liz is one of the founding directors of Jean Hales for Women's Health. She's the head of menopause unit at Monash Medical Centre here in Melbourne, and she's also a consultant gynaecologist and the acting senior medical officer at our clinic here in Melbourne, our two clinics. Dr. Farrell's been actively involved in menopause management and education for more than 20 years, so she's a great wealth of experience. So I'll hand over to you, Liz.
Good evening, and I hope that you all enjoy the evening. I just want to go through a few small definitions to remind you that the menopause means the final menstrual period, that we say that someone is postmenopausal when they're 12 months after their final period, that the perimenopause, although we really don't have any absolute markers for when the perimenopause commences, but we use a menstrual marker as being the guide for most women as to the onset. We know that early menopause occurs between the ages of 41 and 45, and probably around about 8% of women will be menopausal by 45, and premature menopause, the final menstrual period, being before the age of 40. And that's probably about 1%, and under 30, about 0.1% of women will be postmenopausal prematurely. Now, if we look at the geographical variation, and we find that, in fact, most women become menopausal between about 48 and 53. In Australia, it's around about 51, but in many parts of Asia, and also you can see on the screen in the United States, it's 49. And I've just come back from Mongolia, and the studies there have shown that menopause occurs about 49 as well. If we look at the expectation of women, life expectation of women at the age of 50, on 2011 data, approximately 35 years will be lived after the age of 50. So it is a very long period of time in a woman's life. And for that reason, it's very important for us to make sure that women's quality of life is maximised. I just wanted to remind you of the complexity of the endocrinology of the menopause, and for those of you who did the pre-reading of Professor Susan Davis's article, then you will understand that the perimenopause is an extremely complex time hormonally in women's lives, and that there are many issues that are raised during that time, which fall into having many different symptoms, and the symptom range can be of high estrogen. So the perimenopause can be considered in many stages a hyperestrogen state, but also women can present with symptoms of lowered estrogen, the classic vasomotor symptoms. And then, of course, postmenopausally, the symptoms that don't go away are the vaginal symptoms, and renamed now the genitourinary syndrome of the menopause, to include sexual changes as well. I remind you that the majority of women will have some symptoms, with only about 20% stopping their periods and not having symptoms, and at the top end, about 20% of women who will have symptoms that impact on quality of life. Please don't check a woman's FSH, LH, estradiol or testosterone levels if they present in the perimenopause. due to the complexity of the endocrinology, it does not help you in being able to treat a woman's symptoms, whatever they might be in the perimenopause. And as Deirdre has said, it is most important to take a good history, making sure that you evaluate the risks and the benefits that women have at this time in terms of management. And it's better that you offer help rather than doing a blood test. So if we look at the experience of the menopausal transition and the menopause change, there are many factors which will impact on a woman's experience of the menopause. And it depends on all of those issues that are listed there on the slide. And depending on the impact of those other factors, the symptomatology of a woman may be very relevant. And so therefore it's important to take the history to exclude other factors that may be part of her experience. So what do we do? Well, simple measures are easy. Just advising women to dress in layers, have a fan, all of those things. But there are obviously many therapies that are available that are across the spectrum. From the simple measures, there are the therapies that we're going to talk about tonight, prescriptive, non-prescriptive, herbal, and of course some women may also require the need for therapy or counselling. And just finally to talk about the issue of hormone replacement therapy, that it is an appropriate therapy in women who are fit and healthy, but it should be part of an overall management process. Then, of course, it's important to look at the risks and the benefits and to make sure that the woman does not in fact fall into a category where hormone replacement therapy may not be the most appropriate area for her. Thank you.
Okay, we'll just finish that poll. Okay, now I'd like to introduce Sandra Valella. Sandra is a naturopath and herbalist who's been in practice for more than 20 years. She uses herbal medicine as well as nutritional medicine, nutritional supplements and dietary advice in her practice. Sandra's interest in women's health, particularly in the management of menopause. She's keen to bridge the gap between natural therapies and conventional medicine to achieve complementary health. She's driven by a desire to make a difference, particularly encouraging women to make positive changes with nutrition and lifestyle. Thanks, Sandra.
Thanks, Louise. So I'm going to talk a little bit about what we know about the use of complementary therapies in Australia, and thank you to the Medical Journal of Australia for having a very relevant paper released early this month, which I'll talk about, and also touch on efficacy and the issue of safety, which is often a concern for practitioners. So early this month, a paper was published in the Medical Journal of Australia. It was a research done by Monash researchers in Melbourne, and it gave us a really good insight into what women are actually doing and using in terms of complementary therapies. It looked at over 2,000 women in Australia, and it showed that over 13% of women are using complementary therapies particularly for hot flushes, for the vasomotor symptoms. But very interestingly, what they're using are not necessarily the most appropriate choices. So in order of the use, it was phytoestrogens, evening primrosal, and ginseng. So phytoestrogens efficacy really varies, and it really depends on whether you are one of those third of the population that contains a bacteria in the gut that allows for the metabolism of the isoflavones in soy to be metabolized to a more potent phytoestrogen, and those women are more likely to get efficacy. Evening primrosal, again, is one of those remedies that people often self-prescribe. It is often prescribed by practitioners, and it's been shown to be no better than a placebo. And again, ginseng, it's one of those ones that wouldn't be the first choice of most of my colleagues, but again, this is what women are choosing. So it begs to ask the question, where are women getting the information from? Very interestingly, only about 8% of people, of these women, actually consulted a complementary therapist for the advice on hot flushes, and they're more likely to see a chiropractor, 2.78%, than they were to see a naturopath. So less than 3% were actually seeing a trained professional to get advice. So it does show that women are actually self-prescribing, and that's not actually ideal. The full journal article is available if you click on that link. So in terms of efficacy, one of the criticisms of complementary medicine is that there is insufficient evidence or that it's not evidence-based. And indeed, there are some complementary therapies that are absolutely being shown to be effective, such as the good research that's on St. John's wort, some research on black cohosh. And otherwise, the quality of the research does actually vary, and between research, absolutely. There is one of the things we need to keep in mind, that while the randomized controlled trial is the gold standard, levels of evidence are important, and in fact the World Health Organization do actually look at a different way of assessing traditional medicine and looking at efficacy in a different way to the standard levels that we look at. And we also need to look at product, unfortunately, and the quality. While we think that in Australia we're very lucky that we have good quality, people are often sourcing things from overseas and they're not necessarily as good. So for example, when it comes to black cohosh, most of the research is either done on the product Remifemin or the Flautas product Femula. And they're the ones that are showing that the research is better than some of the others. It's also important when we look at safety that we look at product, and then we separate that from the practices. So there is the practices that that practitioners are using, and then there is product. So there are cases, of course, of adulterated products, and they're often not so much in Western medicine, but in Western herbal medicine, but often in Chinese medicine. And then there are we do need to keep in mind there are fewer side effects compared to pharmaceuticals, but there is probably an underreporting. So they're overall seen as being safer, but there is also this misconception that because they are natural, they're safe, and so anybody can prescribe them. In terms of reactions, we have predictable reactions, like for example, if we look at what happens with St. John's wort, we know that it affects the liver enzymes, and there are predictable reactions that occur with certain medications. And then there are unpredictable ones, or allergic or idiosyncratic reactions, like what has occurred with some of the rare cases of black cohosh, where it's called caused liver damage. Now I'll talk a bit about this during the cases, but black cohosh is not a hepatotoxic herb. It is an idiosyncratic reaction that occurs in very few women, and most of the cases, there are about 70 worldwide, and now it's been shown that probably one of those cases is probably related to black cohosh. And again, this whole idea that just because it's natural, it's safe and harmless, where ideally it is best prescribed by someone who's trained in the profession. One of the concerns for medical practitioners about complementary medicine is that people are using these complementary medicine and then they're delaying or a diagnosis and treatment, or that they're using these complementary therapies instead of their own treatment, and there's a loss of benefit of that therapy. Ideally, and one of the things that we try and do here at Gene House is foster a collaborative relationship where these well-trained complementary practitioners are working with medical practitioners, and that's going to be in the best interest of the care of the patient. Unfortunately, it is an unregistered profession, and most of my colleagues are pushing for registration, but at this stage it means that anyone can be a naturopath and just put up a shingle and practice without any regulation, so that is a bit of a concern.
Great, thanks Sandra. And last but not least, I'd like to introduce Dr. Mandy Deeks. Mandy is a passionate psychologist, and her background is in translation, education and research and clinical care in women's health. She's head of the translation, education and communication area at Gene House for Women's Health, where I work, and the deputy chair at both the Royal Women's Hospital Human Research Ethics Committee and Melbourne IVF Human Research Ethics Committee. And tonight, Mandy's going to focus on the psychological aspects of menopause. Thanks, Mandy.
Thanks, Louise. I think one of the things that I always try and stress when we talk about menopause is that we know that menopause doesn't happen in a vacuum. We need to consider the context of a woman's life, and I quite like this quote from Wolfutian, who said really that psychological, social and cultural aspects of menopause, as well as lifestyle factors, play major roles in the menopausal transition. So it's just something for us to keep in mind. And when we look at all the research, a question that I'm often asked is, does menopause cause depression and cause anxiety? Surely there has to be something going on that means menopause results in those mood disorders or dysfunction. What we actually know is that depression and anxiety is more likely to be predicted by these factors, and that includes a woman's personality, her genetic and family background, whether she's actually experienced prior negative mood. That's one of the bigger ones, along with health status. So what else is happening in a woman's life in terms of her health? And when we talk about those factors, we're thinking about perhaps cardiovascular disease, diabetes, other lifestyle-related diseases. Lifestyle is really important. We know that women who perhaps aren't physically active, who perhaps aren't eating a nutritious diet, tend to experience more menopausal symptoms. We also know that a negative body image predicts depression at the menopause and midlife time in a woman's life. The domino effect, so if a woman is experiencing severe vasomotor symptoms, she might have been up all night with night sweats, her quality of life is definitely impacted, and that domino effect of menopause impacts on mood. Partnership status is another really interesting piece of research that consistently shows up in both community and clinical studies, that shows women who are in satisfying relationships tend to have a better menopause experience and less mood dysfunction. How women handle stress and the daily hassles of life, and very much around coping skills. So sometimes women will come to me and they will talk about coping skills that have always worked, and suddenly in this time perhaps of hormonal chaos, those particular ways of coping aren't working so well anymore. So it's perhaps looking at the different coping styles of women at that time. And also, interestingly, the research tells us that women who have roles that they feel are satisfying have less intense and less frequent hot flushes. So some of those things are actually more likely to predict depression and anxiety and mood, perhaps high stress, than the actual menopause hormonal chaos. What we do know, however, is in a lot of the studies that while it might not be related to the natural menopause in terms of estrogen, perhaps testosterone, we do know that women who've experienced a surgical menopause or a premature menopause, particularly if it's surrounding a cancer diagnosis and chemotherapy treatment, they are more likely to experience a depression or anxiety that can be related back to menopause. We know when we look at treatment that women who are given estrogen, particularly if they have a mild depressive disorder, tend to improve. But if a woman has more severe or clinical depression, estrogen doesn't necessarily help enormously. I think that the consistent finding of a lot of the research is that a negative attitude to menopause results in more symptoms that are more intense and perhaps interfere more with quality of life. And I've put in there the chicken or the egg, because actually it's quite difficult to know which comes first when you, as I said, are up all night and have disturbed sleep because of your symptoms. That then impacts on mood. And then if you are surrounded in your family by high stress or difficult relationships, that then also starts to affect mood and function. So what to do? Importantly, assess prior experience of depression and or anxiety. Look at the role of the other health issues in a woman's life, perhaps diabetes, perhaps cardiovascular disease, arthritis. We know that women who have cardiovascular disease have higher rates of depression, so that's something else to think about in that mix. Lifestyle, including physical activity. Women who actually exercise for at least 30 minutes a day for at least 3 times a week tend to have less menopausal symptoms. Overall quality of life and that domino effect, how that is impacting. The stress and perhaps critical events that are happening in a woman's life at that time. Her relationship status and the satisfaction with that relationship. Support networks, Women who are isolated tend to experience again a more difficult menopause. Role satisfaction, as I mentioned, and maybe it's not necessarily about the number of roles anymore, but it is about the quality of those roles. So I always like to talk with women about that and where they have their sense of purpose, their meaning in life. There is also the mental health assessment and the potential role of psychotherapy, which is very effective in treating menopausal symptoms at the same time as everything else is going on, and I know we'll talk a lot more about that in the case studies. But another really important thing is counselling if that's needed, and perhaps contacting the Australian Psychological Society, who have a fantastic referral service, is something that you could think about as well for your patients and clients. Finally, another quote to finish on, and I quite like this one because we do sometimes forget the positive experiences that women have. So women's experience of the menopausal transition appears complex, I would say often is complex, potentially involving a range of factors and influences in their lives, and it is by no means overwhelmingly negative. A lot of clients will say to me that it's a time for them. As Deidre mentioned, it's a fabulous time to reassess those health concerns or do a health assessment, and for women to actually focus on themselves at this time. Thank you.
Thanks, Mandy. Well, I think that's a fantastic overview to start us off, and the next hour we'll focus on the case studies. I just want to make note that we've got people online from everywhere across Australia, and I think we've got all states covered, which is lovely, and lots of people from rural and regional areas. So this is really positive for us to see that. So the case studies we'll just leave up on the screen so you can refer to them. And so we're starting with Jenny, a 48-year-old woman. You can see with hot flushes and some typical symptoms of perimenopause. She's worried about risks. She doesn't want HRT. She wants to see a naturopath. And I think the poll showed that I think 50% of you said that patients had a preference for natural therapies when we did that poll earlier. So she's a fairly typical case that you may see in your work. So I'd like to start with Deirdre, as she's more often than not probably the first port of call as a GP. Tell us, Deirdre, about your approach to Jenny.
Thanks, Louise. Well, again, as I said previously, it's just a matter of taking the time to understand what Jenny's going through, developing that rapport, listening and acknowledging her concerns, and also assessing the severity of her symptoms and the effect that they are having on her lifestyle. Finding out what she's already tried, what she's happy to try now, and then moving on to just basically taking the full history and examination that we have all been trained to do. In particular, the menopausal symptoms of the old seven dwarfs of menopause, the itchy, bitchy, sweaty, sleepy, bloated, forgetful and psycho, but also adding into that the urogyny symptoms of incontinence and prolapse, as well as vaginal-vulval symptoms, in particular any dyspareunia that she might be having. Then there's the usual menstrual cycle, length, amount, assessing how much she's losing each month, and any associated symptoms such as pain, any postcoital bleeding or intermenstrual bleeding, and then what contraception she is currently using and what she's used in the past. Does she need a pap smear? What's her history of mammograms? And in particular, and what pregnancies and deliveries that she might have had. So just that complete overview of the history that we've already talked about as well. In terms of the investigations, I'd be doing a pregnancy test. You really can't exclude pregnancy in a 48-year-old. And then moving on to blood tests such as a full blood count, iron studies if you felt they were necessary, liver, thyroid, a fasting blood sugar level, and lipid to assess her cardiovascular risk statement. And in certain areas of the country, a vitamin D would probably be appropriate as well. If she hadn't already had one, I'd be doing a pap smear and arranging for a mammogram, or at least discussing the need for a mammogram in going on to the future, and also recommending that she have an MSU or at least a ward test. As Liz has already said, I wouldn't be doing hormone studies, FSH. They're really of no value in this profile, and nor is an AMH, the new kid on the block. I would also consider some of the other screening measures that we might be able to undertake, such as DEXA scans, whether she should be having fecal occult blood tests or indeed colonoscopies. And moving on to her question for the need for contraception, she says that she's using condoms at the time. She doesn't necessarily need to keep using those, but she does need contraception for at least 2 years after her last period if she's under 50, and for 1 year after her last period if she's over 50. So as an alternative to condoms, she could maybe consider the low-dose pill, although if she doesn't want HRT, she may indeed not want those hormones. But also a Mirena or an Implanon would give her both good cycle control for her irregular periods as well as contraception. Thanks.
Okay, fabulous. I can see how seeing a lady with perimenopausal symptoms is going to take you quite a long time if you're going to do a really thorough consultation, which you've just described. Liz, would you like to add anything else to what Deirdre's approach has been?
I think that what we see in the case history is the complexity of the perimenopause with symptoms of low estrogen that we think the hot flushes can be, the irregular periods, which can be often completely out of sync. They can be also heavy, and some women can develop pain at this time. I think the other aspect of the perimenopause that we have to remember is that there are some cycles in the perimenopause where women can actually ovulate twice in a cycle. They can ovulate mid-cycle, but then another follicle fires, and they can then have another ovulation at the time of their next period. And so this is where, for women who don't want pregnancy, it is important to prescribe contraception or recommend contraception. In those women, they are sure to have very sore breasts, and we know that sometimes with high estrogen, which will help happen at that second ovulation, some women will also experience some degree of anxiety and agitation or mood change with the high estrogen. So we have to look at very carefully what the factors are that are worrying this woman, and what treatment do they actually warrant. And it's often very difficult to find the appropriate treatment to solve all of the symptoms in this particular woman. She's really got the mixture, and so maybe it's not appropriate to even consider something like HRT, but more to look at regulating the cycle by using either the oral contraceptive pill or perhaps even using the Mirena IUD. Thank you, Louise.
There's a question that's come in, and there's been a few of these questions actually. Can we start HRT in a perimenopausal woman who's symptomatic but is still having periods? So this woman obviously doesn't want to go down that path, but if she was happy to, would HRT be advantageous, I guess?
So once again, it has to be a discussion with the woman and you, the health practitioner, as to the severity of her symptoms and the impact on the quality of life. And yes, you could start hormone replacement therapy if she does not require contraception, because you know that HRT is not contraceptive. So it could be started at this stage, but you would use a cyclical regimen and you would try and fit it in with her menstrual cycle as best one can. And so you may decide to use cyclic patches or one of the oral preparations that are of combined estrogen and progestin, but on a cyclic basis. Thank you, Louise.
Another question, sorry, just before I move on to Sandra, someone has asked, would you in this case do a transvaginal ultrasound or an ultrasound, sorry, to rule out fibroids?
Than 3 weekly, or there was any intermenstrual bleeding, or they were much heavier, and there were other associated symptoms such as premenstrual symptoms or pain that were new, then it would be appropriate to do a transvaginal ultrasound. But I think we have to be very careful about ordering a transvaginal ultrasound. You must really get your radiologist to give you the information that you require, and getting a result which says ovaries are normal and the uterus is normal is absolutely a waste of time. You want to have the measurements, you want to know the endometrial thickness, if there's any evidence of a corpus luteum, are there any ovarian cysts, if there are fibroids, how big they are, what is the volume of the uterus, and are the fibroids impacting on the endometrial cavity so that they could be causing heavy menstrual bleeding. So I think, yes, it's a good question. I think that also I wanted to make the point that this is where thyroid function tests are probably one of the tests that one would do, because there is some suggestion that thyroid dysfunction will often present around the perimenopause. Don't think we know why, but it is an indication to actually do a thyroid function test as well. Thanks, Louise.
Okay. Great, thanks Liz. So Sandra, we'll move on to you. This is probably a patient that you would see regularly, and I think, you know, as I mentioned before, our poll says that a lot of women do want to explore natural therapy. So I'll let you give us your points about this case.
Yes, I've noticed that a couple of the questions have come up are asking why she wouldn't use HRT. So one of the things I would firstly do is pull up the GeneHealth website, which actually shows the pros and cons, the risks and benefits of HRT in a very plain language for the woman, and shows the actual facts about, you know, one woman in so many women will develop this and whatnot, to be able to give her the facts so that she's not thinking that, oh, I'm going to get breast cancer if I go on HRT, and then move on to talk about what we could do naturopathically. So in terms of cycle regularity, there's a herb called Vitex agnus castus, and I would often use that. This is well indicated in this woman, and I would particularly use the formula at Primula, which is a standardized extract of Vitex, and that could also help if there's a cyclical nature to her symptoms, so particularly if the nostalgia is just premenstrually, for example, or the mood changes, it might be an exacerbation of PMS, for example. And then I would talk about some herbs that we would use. So these are herbs that practitioners may actually use, and I would think about using the herbs hops, and I'm doing this for a particular reason. And hops does actually contain a very potent phytoestrogen, which can be useful for sleep disturbances and vasomotor symptoms. But because it does have a very potent phytoestrogen, I don't use this if there's any caution around breast cancer, or certainly not in breast cancer patients. And the other two herbs, Ziziphus spinosa and Withania, are herbs that are non-hormonal. So one of the things that naturopaths and herbalists will often do is deal with some of the symptoms without using hormone therapy, for example. This is also when something like St. John's wort might actually be appropriate for a woman and she doesn't have any contraindications, and particularly St. John's wort with black cohosh is often used quite regularly, quite often in Europe, and for the management of a range of perimenopausal symptoms. So that combination may actually be useful for her. Of course, exercise is really important. As Mandy mentioned, women who exercise more than 3 times a week for 30 minutes, it does tend to have less menopausal symptoms. She's concerned about her weight gain, and particularly if she's exercising in the morning, that will help with her moods as well. Thanks, Louise.
There's a question, Sandra, do we need to do a baseline liver function test before starting on natural therapies?
I would imagine that the question with that is because the cases of liver function, of liver toxicity that have occurred with black cohosh, and as I mentioned, it's not because black cohosh is an hepatotoxic herb. It's a very rare idiosyncratic reaction that occurs in a very minor amount of women, and in fact the Therapeutics Goods Administration have actually said that black cohosh is a safe remedy to use given its widespread use. And the latest research, which has gone through all of the cases, have ruled out of the 69 cases that one is probably related to black cohosh. So no, there wouldn't be a need to do a baseline liver function test.
Okay, great. Thanks, Sandra. And now, Mandy, if you'd like to comment on this case study, and I think it's really nice to notice that the poll where we asked if people were routinely doing psychological assessment, I don't know if you saw the results of that, but it was a really high number, which is great to see that if people are coming in with menopausal symptoms, that people are actually assessing their psychological state, which I think is really positive.
It's really positive. It's brilliant. I did see that, so thank you. I think Liz mentioned that there's this sort of chaos, this hormonal chaos around perimenopause, and I think that Jenny is a good example of that, and the mood swings, the mood changes. So I think that's the first thing to note, that we do know women who are experiencing the perimenopausal transition do tend to have more of those swings of mood, not necessarily depression and anxiety, but definitely the highs and lows. So it's about understanding what those are, and it's a perfect opportunity to perhaps jump in, not necessarily be overreactive or defensive, but to assess a woman's mood as you are doing, which is brilliant, and understand what else is happening in her life at the time. I know that one of the things that one of the questions that we've had asked as part of the webinar is, how can we support women with fluctuating moods? And I think this is an excellent opportunity to answer that question in relation to Jenny as well. First off, it's about monitoring the mood and understanding what the swings and whether it's anxiety, whether it's depression, what else is going on and what else is interfering, whether there is a clinical diagnosis of depression or anxiety. We have the better access and the mental health plans, which also help women at this time of life to access a psychologist. And it might only be for a couple of sessions just to normalise or just to understand what's going on. Treating the actual physical symptoms of the menopausal transition will have a huge effect on mood. So again, if women have their hot flushes under control a little bit, then perhaps that improves their overall quality of life. A lot of women will talk to me about a hot flush being a little bit like a panic attack. And when they first start, so in those early years of menopause, they can be quite off-putting, quite distressing. So it's teasing out whether this is an anxiety-related panic attack or this is the presentation of hot flushes. So treating that physical symptom of menopause will help enormously. Strategies such as relaxation are very, very important. There are a lot of really good randomised controlled trials and research studies that show the benefits of relaxation to controlling hot flushes and night sweats. Exercise, as I've mentioned and Sandra's mentioned, and lifestyle. And there's also cognitive behavioural therapy. And then down the track, SSRIs also are very effective, not only in controlling mood changes, if Jenny does present as clinically depressed or clinically anxious, but they may also help with the vasomotor symptoms. So that's where I'd be thinking about with Jenny. Thank you.
Okay, great. There is a couple of questions about weight gain and that being a big issue for people's patients and their major concern, I guess. Would anyone, I know we've talked about physical activity, but would anyone like to kind of address that question specifically? I know there's no magic answer, but if any of you have a comment to make on how we tackle that. See, this is how difficult it is. Sorry, we didn't catch that, Liz. Could you start again?
Yes, I think the issue about weight gain is quite complicated, and it's related to changing shape, body shape, and that's due to the changing sort of ratio of estrogen and testosterone. So our body shape changes from being pear-shaped to apple-shaped, and that's because of that change in estrogen and testosterone. The estrogen drops, but our testosterone is just slowly diminishing with time and doesn't have that rapid change. And also there seems to be a slowing of metabolic rate, and so that women having a normal diet tend to put on weight. Also, as we age, we tend to be less active, and so that's important where lifestyle issues and exercise come into play. Thank you.
Okay, thanks, Liz. We'll move on to part 2. So we're still with Jenny, who's now reached menopause at 50. And sorry, she reached menopause 2 years ago. She's now 52. She's now having terrible symptoms that have worsened. She's finding them unbearable. She's been to see a naturopath, and now she would like to be, well, I think the naturopath wants to refer her back to the GP. She's had black cohosh, as Femula, as Sandra's mentioned, and now wants to go back to the GP for some advice about HRT. And we've got some information about her family history there. So Deirdre, your approach now with Jenny these years later.
Thanks, Louise. Well, again, it would just be assessing how the symptoms are affecting her quality of life, what specific symptoms she does have, and assessing what measures she's taken and how she now feels about HRT as well, and whether there's some more information that we can give her with regard to that. In terms of in 4 years, things can change in women's lives. It can change in their social situation, whether they have new partners, whether their caffeine, alcohol, smoking, medication list has changed. And so this is a good opportunity to start to update those details that you'd have in your practice notes as well. There's also an opportunity to again address the screening side of things, doing a calculation of both the FRAX risk and the CVD risk, and repeating any of the investigations that you might need to from before. So basically it's about just assessing her symptoms and her risk factors. Doing a pap smear might be a good opportunity for you to bring up the topic of vulval symptoms and dyspareunia, and just going over once again assessing the whole woman as a. Thanks.
Okay. And obviously the HRT is going to come up in discussions here, but because Liz Farrell's here and she's our expert in HRT, this is probably something that you would normally do, Deirdre, in your practice. You would be initiating HRT treatment.
Absolutely. I'd certainly be discussing it, and depending on the individual situation, absolutely we'd be either recommending it or at least talking about it to her and the benefits, the risk and benefits of it. So yeah, that's certainly something that GPs do on a very regular basis. The whether or not you refer her to a specialist for that would depend on your own feeling, on your own comfortableness with it, and whether you felt that you were whether it was within your scope of expertise. And I know certainly that many members of GPs that I've worked with actually would inter-house refer to another GP in the practice that they might feel is more comfortable with dealing with those issues.
Okay, that's great. And I noticed the last poll too was asking patients about the symptoms of the urogynecological symptoms, so vaginal dryness, and it looked like a lot of people were routinely asking, which I think is great. Now we're going out of our previous order, so I'm going to ask Sandra to make a comment on this case before we actually go on and talk about HRT with Liz. So Sandra, would you like to give us some suggestions for this woman?
Yes, okay. So she's now taking the black cohosh. Now, in light of her family history of breast cancer, as I mentioned before, if she was taking the hops, if she had been taking the prescription, if I was the naturopath, then I'd certainly not be recommending that she takes the hops. as that does contain that potent phytoestrogen, and we don't know about the safety around that with breast cancer. But black cohosh, on the other hand, does have some safety data around it in terms of breast cancer patients. So there is research that is done in vitro that shows that it doesn't have a direct estrogen effect, or it has an antagonistic effect. There is some research in vitro that shows that it may actually help with the way that tamoxifen works, and there have been 3 trials that have looked at breast cancer survivors and the use of black cohosh, and particularly with the last one, it showed that in fact it seemed to have some sort of possible chemoprotective effect. So women who were taking black cohosh actually had a longer time before they had a recurrence of breast cancer compared to those who didn't. With her family history of diabetes, and this brings up the weight issue, again, her weight is one of her concerns. And one of the things that I often talk about, and as Liz has already talked about, there's many factors that are involved in it, but exercise is really important. And I know there was a question here about what about the woman who is too tired to exercise. It kind of has this positive effect. You kind of can get them exercising, and then that will often improve the energy. And, you know, again, sleep disturbance can have an impact as well. The sleep disturbance can have an impact on weight because it affects some of the hormones that control the appetite, like the leptins and the ghrelin. So ensuring that sleep's taken care of can often have an impact on weight. And particularly with her weight, we'd be looking at trying to get her waist circumference ideally under 85 centimetres. As we all know, 85 centimetres is not very big in a woman, and above 85 centimetres there's a significant increased risk of cardiovascular disease, metabolic disorders, and ideally it should be less than 80 centimetres around her waist. Bone health is really important, so looking at calcium, adequate calcium, to meet her needs. So if she's postmenopausal now, then her needs will be 1200 milligrams to 1500 milligrams. So if she's only getting 600 in her diet, you need to supplement up to that amount, and vitamin D supplementation with that also needs to be looked at. Sleep hygiene, in terms of looking at the amount of caffeine that she's having, ensuring that she's not doing work and playing on her computer or checking her emails before she goes to bed, and alcohol is really important. So we know while alcohol might help us to get off to sleep, it's more likely to cause more waking through the night and certainly exacerbate those nighttime hot flushes as well. Thanks, Louise.
Okay, great. And Mandy, sorry, Liz, I'll go to Liz now. What's your take on this woman and her HRT request?
I think she's a good candidate to go on HRT. Yes, there is a family history. There are no first-degree relatives. We don't actually know the age of the first cousins at the time of the first cousin who at the age that she developed breast cancer. So at this point in time, her quality of life is the big issue. She's finding them unbearable. So that means that she's really struggling to function properly. And so we know that hormone replacement therapy is the most appropriate therapy for women with severe menopausal symptoms. She personally doesn't have any contraindications on the history we have there to take hormone therapy. We know that going on to HRT around the age of menopause and within 10 years of the final menstrual period in women who are fit and healthy is in fact very safe. The risks are small, and it depends on what products that one would suggest in this particular woman. So we tend to be prescribing more patches, and there are combined patches that we can use quite readily, changing them every 3.5 days, twice a week. The side effects with patches tend to be perhaps less than oral therapies, such as a lower risk of thrombosis compared to oral therapy. The absorption is directly through the skin into the bloodstream. We're avoiding the first pass part of metabolism. We're using obviously estradiol, which is a bioidentical estrogen, and norethistone, which is a synthetic progesterone. This product is on the PBS. So from the point of view of cost, it is within most people's budget. Looking at other therapies, we could use oral therapy, particularly combined therapies, particularly in a woman who perhaps has atopic skin, who has an allergy to adhesives or glues or band-aids, and then we'd be looking at a combined therapy, continuous therapy at this age. She's now 2 years after her menopause. She's probably reached the lower level of estrogen. Takes about 2 to 3 years to get that lower level down to its lowest level, its nadir, and then it stays at that level for the rest of a woman's life. So I think she's a good candidate for hormone replacement therapy. We take into account her family history, but we should start her off on the lowest possible dose and then reassess her response to that. Thanks, Louise.
Okay, that sounds great. Look, there's just a couple of questions that we might do before we move on to our second case study. One is in a woman who has migraines, and there's been a few of these questions, or hypertension. What is a suitable HRT, or what would you choose, Liz?
So let's take the migraines. So it depends on what type of migraine they are. We know that there's definitely a hormonal relationship between migraine without aura, and we know that we often see it premenstrually or menstrually. And in some women, their migraines will get worse with menopausal change. So if a woman has severe symptoms like Jenny, and she has migraines without aura, then going on to hormone therapy is probably quite appropriate. And some of the studies have shown that, in fact, using higher dose therapy in those migraine sufferers is appropriate, and to use a combined continuous regimen. But with people with migraine with aura, we know that we don't prescribe the oral contraceptive pill for women with migraine with aura. But there is no data on those women with HRT. So depending on her menopause symptoms, you would perhaps trial the patches, and perhaps even starting with a low dose patch, or even using the combined patch and cutting it in half to see how she responds to that. With regards to someone with hypertension, somebody who has uncontrolled hypertension should not be commenced on hormone therapy until the blood pressure is controlled with medication, and then we would then prescribe, preferably once again, perhaps using patches instead of oral therapy. We do know, however, that some of the literature on Angelique has shown a slight lowering of blood pressure. So if the woman doesn't want to take patches, then perhaps Angelique would be the appropriate therapy for her if she can afford to purchase it. Thanks.
Mandy, sorry, I'll come back to you now. Could you just describe how you might approach this lady who's now back, some years later with terrible symptoms?
Thanks, that's fine, Louise. And I won't actually go on too much, because I think some of the key messages have already been discussed. I think something that Deidre has said and reinforced is, for someone like Jenny at this point, it's going to be really important to actually listen, to really understand what's happening in her life. There's that whole piece around the anxiety that she might be experiencing in relation to family members who've been diagnosed with cancer, and all the information and literature that's out there in the media on HRT and cancer. So it's unpacking some of those fears and drilling down and really listening to what she's saying. And I think that we all know when patients and clients feel that they've been listened to, that we are so much further along in helping them. The other comment that I would probably make is I know that when women feel at this time that, and we've described Jenny's experience now as unbearable, it's almost like she doesn't quite know where to go. And for her, this is almost getting to the end of the road. So it's about trying to find ways to give her control back. And that may very well be through improving quality of life, through treating the physical symptoms, but it might also be around the talking and listening. And it might also be through things such as a bit of cognitive behavioural therapy, where we know again from the research and the literature that that actually does have a really significant impact on menopausal symptoms, particularly hot flushes and night sweats. So it's about understanding her anxieties, and it's about giving her back some control. And it can be tiny little things, and this might be where, even though it probably is the last thing she might want to think about, but it's finding ways where she does get some joy, turning some of the negative into the positive, and perhaps looking at her thinking styles and things like that in that cognitive behavioural setting. So they're just a couple of things that I would be considering with her, and keeping that relationship going, and making sure she's getting, the best advice and treatment that she can. Thanks, Louise.
Thanks, Mandy. Sorry, before we move on, there's just two more quick questions. Would tibolone, this is for you, Liz, would tibolone be suitable for this woman?
Yes, tibolone is another option. As you're aware, it has the actions of estrogen, progesterone and testosterone, and it has benefits on maintaining bone density and reducing fracture risk. It has a very positive effect on vaginal dryness and vaginal secretions. It increases free testosterone by decreasing SHBG, and it's effective on menopausal symptoms. It also doesn't seem to have the same degree of stimulation on breast tissue, because it seems to block a couple of the enzymes within the breast tissue, and so therefore the number of breast side effects are less. And also, if you compare Liviol or tibolone with combined oral estrogen and progestin therapy, the manographic density is less with Liviol. I think that it's a very good therapy, but it is very expensive. Even the generic brand is only a couple of dollars cheaper, and really it is not a medication for those people who obviously are on lower incomes. I think that at the moment, for those women who go through menopause at the expected age and are suitable for HRT, then they need to, you could try some of the newer formulations of Formostin. So we've got low-dose Formostin now. They're all on the PBS, and they contain estradiol and dydrogesterone. So it raises the issue of what is the most appropriate therapy that we should be using. And at the International Menopause Society last year, they recommended that we should be using transdermal estradiol and oral micronized progesterone. But we don't have oral micronized progesterone in Australia, even though it's been around for more than 20 or 30 years. It's available in most countries, including New Zealand, but not here in Australia. So obviously the closest progesterone the closest one to micronized oral progesterone is Dufaston or dydrogesterone. So the combination of oral estradiol and oral dydrogesterone is a reasonable combination to start with, and it's, as I've said, it's on the PBS. There have been a number of questions about bioidenticals. Well, bioidentical therapies, all of the estrogens that we use are bioidentical in prescriptive HRT. All of the progestins we have are synthetic progestins. All of the hormonal products that are available, whether they be bioidentical or not, are synthetically made in a laboratory, and they're not made from plants. They're not squeezed out of various soy or black cohosh or whatever. Mexican yam, that's the other one. But in fact, they're synthesized. So any bioidentical hormone basically has the same risks and benefits as any prescriptive combination of therapies. But what is interesting is that there's been some data recently published looking at the particular risks of the different progestins, and it would appear that those that have the higher risk of thrombosis and also of breast cancer is in fact medroxyprogesterone acetate, or Provera, and of course that has been the main progestin studied in HRT studies around the world, and of course was the progestin in the WHI study. So there seems to be a step-down effect where dydrogesterone and progesterone seem to have a safer profile compared to medroxyprogesterone acetate. Thank you.
Okay, we'll move on. Look, there are more HRT questions. If we don't get to them, and some of them around cardiovascular, increased cardiovascular risk factors for people with PCOS or type 2 or type 1 diabetes, but we might have to come back to those at the end if we have any more time, because I think I'd really like to get to the third case study. So I'm running out of order here, but this was really because there's been quite a lot of questions come up when people registered around how to manage menopausal symptoms in a woman with a past history of breast cancer. So we're going to move on to case study C, which is Lena, who's diagnosed with breast cancer. I'll let you read the specifics of that. So she's had chemo, she's had an immediate onset of menopausal symptoms, and she's got quite a few concerns, not surprisingly. So yeah, if we'll perhaps start with you again, Deirdre, to talk about Lena. So just note we've moved on to the last one, not the second case study.
Yep. Thanks. Wow, Lena's really struggling, isn't she? So I guess as her GP, I'd be once again giving her the chance to express all of her symptoms and her concerns about her life, listening, providing the time, seeing if she has been given any advice on the simple methods of managing some of those symptoms, such as fans and water sprays, layers, etc. Giving her advice as to the vaginal lubrication and moisturisers that you can, first of all, the non-hormonal ones such as olive oil, sweet almond oil, and the Replens and Silk that you can get. And once I've sort of covered those and given her the relative time, I'd be thinking about referring her to appropriate specialists for things like sexual counselling or sexual therapist, and also some relationship counselling, and not underestimating the very good multidisciplinary teams that are available, certainly in some states. Thanks.
Okay, and because there's been a lot of questions about what's suitable for use in a woman with breast cancer or previous history of breast cancer, Liz, could you talk to us about the non-hormonal approaches?
Thank you. So we have a number of, we're rather lucky in Victoria where we have two menopause after cancer clinics, one at the Royal Women's and one at Monash Medical Centre. So we have slightly different management techniques, but there are obviously 3 groups of therapies that are used, prescriptive therapies that are used. The first group that was studied was really the SNRIs. So venlafaxine was probably one of the first antidepressants studied, showing about a 60% reduction in hot flushes and sweats, and we're talking only about those 2 symptoms. Then over the years, many of the other antidepressants have been studied, and probably one of the last studies that have come out in the last 2 or 3 years has been with escitalopram, giving approximately the same degree of reduction in sweating, with slightly lesser side effects than perhaps the venlafaxine. The desvenlafaxine has also been studied and shown to be effective, and a number of the others. Paroxetine in a small dose has recently been registered by the FDA in the USA for the treatment of menopausal symptoms after cancer. But paroxetine and fluoxetine should not be used in women after breast cancer who have who are on tamoxifen, because there has been some increase in the rates of recurrence due to them both competing for similar liver enzymes, and so reducing the effectiveness of tamoxifen. So we would use in our Monash clinic escitalopram as a first-line therapy. Obviously it's also going to help mood. We would then, if that was not suitable, we would consider either switching to or perhaps adding a gabapentin as our next choice. Gabapentin has been studied. The dose, the recommended dose, is about 900 milligrams a day, given mainly at night, and sometimes we would use both therapies together, and that seems to be in some cases more effective than using one or the other. And then thirdly, the old-fashioned treatment, which has been around since the 1980s, is clonidine, and that's probably the least effective of all. Sometimes women develop side effects with both groups of medications, and with the gabapentin, drowsiness and affecting their ability to function during the day may be a significant side effect. And with the antidepressants, particularly with the SNRIs, we must remember that sweating and flushing are side effects of those therapies, and so we have to be cognizant that the symptoms don't increase when we put people onto those medications. Now, I think that the complexity of women who present like Lena are that we're not just treating her flushing and sweating, we're treating all those other issues, including her vaginal dryness and discomfort. And as Deirdre has mentioned, some very simple techniques have been studied using olive oil and pelvic floor relaxation to try to improve the pelvic floor and reduce pelvic floor pain with intercourse using olive oil as a lubricant. So I think I'll talk a little bit more about vaginal estrogens, but I will do that after after the others have spoken, I think, Louise.
Sandra, can we go on to you for this lady?
Yes, okay, so this is pretty much the patient I saw this afternoon, in fact, where they do present with post-breast cancer and looking at their options, and these are the concerns that she certainly had: the flushing, the hot flushes, the joint pains, the vaginal dryness, and one of her greatest concerns was the weight gain. So one of the things that we often talk about is black cohosh as an option for the use post breast cancer, and it certainly is one that's appropriate. I generally would write to their specialist, their breast specialist or their oncologist, and in all but one case the oncologist or specialist has always said yes, black cohosh is appropriate because they are usually up to date with the safety around breast cancer and black cohosh. We also, as mentioned before, it's not all about just using hormonal herbs. So we would often be using non-hormonal herbs, herbs that might actually be useful to help with sleep, herbs that might actually be useful to help with mood, and that will in fact help with her quality of life. With the vaginal dryness, in the late 90s there was a research done in Melbourne actually on using 2 dessert spoons of linseeds or flax seeds that improved vaginal dryness. So they tended in the research to plump up the vaginal cells. So I would often recommend 2 dessert spoons of linseeds, freshly ground, not the linseeds oils, and in fact one of my jobs here at Jean Hales is to create recipes, and several magazines ago the recipe was based on the 2 dessert spoons of linseeds, and we created these muffins that contain 2 dessert spoons of linseeds per muffin, and in-house we call them our juicy vagina muffins, but they are quite delicious and they would be appropriate to recommend. The other things that might be appropriate, some of my colleagues do make up a lovely black cohosh cream. This is something that a practitioner would do that would help with the vaginal dryness as well. And it's also important to address the issue around phytoestrogens. And certainly my patient this afternoon came in saying, look, I'm just confused, you know, what is it? Can I eat soy? Can I not eat soy? And what we do know is that in between 2006 and 2009 there were several systemic reviews and meta-analysis which showed that breast cancer patients can take soy isoflavones. So there were several findings that came out of that. If women who ate soy in a diet that's about consistent with an Asian diet, so an Asian diet's very much higher in isoflavones than a Western diet, 50 milligrams, 25 to 50 milligrams of isoflavones compared to 2 milligrams in the Western diet. If a woman ate a diet high in these isoflavones, she had a reduced risk of breast cancer in her lifetime, and her risk of breast cancer was actually reduced even more if she consumed the diet before puberty. The other finding was that women who were survivors of breast cancer, if they continued to eat a diet high in soy, again consistent with an Asian diet, they had a better prognosis. So in fact this was greater in Asian women. What also was shown though, what was questioned, is that we don't know what highly processed soy products do or supplements do. So there's a caution and perhaps I would say a contraindication about using supplements and highly processed soy with women who have breast cancer. In terms of her overall health, I would be promoting a diet really high in colourful fruit and vegetables, looking at antioxidants, and particularly including the brassica family, excuse me, so the broccoli family, which tends to be associated with a reduced recurrence of the estrogen-dependent cancers. And again, exercise is really important. Excuse me, good evidence around helping with reduction of recurrence and of breast cancer with exercise, and also in terms of helping with mood as well. Thanks.
Okay, great. Thanks, Sandra. And Mandy, let's hear from you.
Thanks, Louise. So there's, as we've heard, there are a lot of things going on for Lena, and I think one of the things that perhaps comes as a bit of a surprise to women who've been diagnosed with breast cancer and go through the chemotherapy is menopause, particularly when you haven't necessarily reached the age of menopause. I've had clients who've come to see me who weren't told that perhaps menopause was a side effect, although I think that that's definitely improving now as there's more information around. So actually some education on menopause at the time and understanding what it is and what the symptoms are and what the implications are. And I know we've had a question that actually said it would be a good idea to also educate the men in women's lives, and I agree wholeheartedly that to actually bring men into the consultation and for them to hear if it's appropriate and if men and their partners feel comfortable, to help them along the journey as well can be really important. It's being mindful that Lena is experiencing a cancer diagnosis, treatment, and then menopause, and so allowing her to focus on what are the issues that are important to her. There are, as I've mentioned previously, very effective strategies and a lot of really good research around cognitive behavioural therapy and relaxation and exercise. So I've mentioned them before and Sandra has as well. It's really trying to establish some kind of quality of life for Lena as best that is possible, and that might also be through support networks. There are some specific symptoms that Lena is concerned around, and that's body image, that would need to be addressed, and it could be very effectively addressed through some counselling. The weight gain and the impact that that's having on her life, the loss of libido and the impact on the relationship. So whether that's bringing her male partner to perhaps some couple therapy as well as some education, they would be some of my suggestions. Thanks, Louise.
Yeah, there's certainly a lot to consider on top of the menopause that Lena's experiencing. Liz, can we just quickly come back to you? And I'm really aware of the time and we want to make sure we address the last case study. But there is sort of some controversy, I guess, about the use of vaginal estrogen in people that have experienced breast cancer. So could you just take us through your thoughts on that?
I've recently looked at all the literature on vaginal estrogen and the role of vaginal estrogen in vaginal dryness after breast cancer. I think although there are no long-term studies, the amount of absorption is minuscule. The estriol absorption with Ovestin cream is, and also with the Vagifem Low, there is good data to show that once there is an initial increase in absorption, it really goes to a very, very low estrogen level and minuscule amounts are absorbed. And I believe that using the Ovestin and Vagifem Low 2 or 3 times a week, not using a 2-week use initially, but just starting with the 2 or 3 times a week and using it once or twice a week on a long-term basis does not have any long-term risks. Thank you.
Thanks, Liz. That's great. We have to be pretty quick with this last case study. And I think for most practitioners or GPs anyway, they may refer on a woman with premature menopause. But this person, Anna, has presenting with secondary amenorrhea for 6 months following ceasing the pill. So Deirdre, if we could just hear from you about your thoughts on Anna.
Sure. So I'd be starting off with taking a history of both this and doing examination of both the symptoms to first of all exclude pregnancy, because you need to do that, but then also to exclude the other causes of secondary amenorrhea. And the things I'm be looking for are thyroid dysfunction, both hypothyroidism and hypothyroidism, pituitary tumours and the associated hyperprolactinemia, PCOS as a cause of her secondary amenorrhea, looking at also other causes of hyperandrogenism with the investigations such as congenital adrenal hyperplasia, Cushing's disease and adrenal tumours. Taking a history in terms of her lifestyle, her exercise, her stress levels, and what her eating patterns were like, in particular the presence of any anorexia, what medication she's on, and also the possibility of intrauterine adhesions and Asherman syndrome from a previous curette. And then looking at some of the risk factors in the history for premature menopause, such as family history. It increases the risk up to about 12 times of that, as well as smoking. And a history of epilepsy also increases the risk of premature menopause. Some of the other causes of premature menopause, such as chromosomal and autoimmune diseases, I think Liz might be covering later. So the investigations, I'd be doing some basic hormone levels, some thyroid hormones, some prolactin, maybe measuring androgen levels, Transvaginal ultrasound, in particular asking to look for the ovarian follicles, ovarian size. And if I did think that there was a chance of PCOS or PCOS had been diagnosed, then I'd be doing her cardiovascular, fasting blood glucose and fasting lipids again. So, thanks.
Great. So Liz, we'll go on to you. What the next steps are once that cause of the secondary amenorrhea is cleared up.
So before Anna is referred on from the GP, we like to that you as the general practitioners would do an FSH level, and that if it's more than 40 and that she's had 2 tests done within a month of each other or 2 months, then and you've excluded other causes of secondary amenorrhea, then it would be appropriate to refer on with the history of premature menopause, either to your local gynecologist, or if there is a premature menopause clinic like we have at Monash Medical Centre here in Melbourne, and of course the Royal Women's Hospital here in Melbourne. But going and then seeing a practitioner or an endocrinologist to exclude the cause of premature menopause. Alternatively, because her big issue is of trying to get pregnant, it may then be appropriate to send her on to a fertility specialist immediately. And and prior to going, you could do, if she is still having the odd period, a day through FSH and estradiol if she's menstruating, and then send her on to the fertility specialist for treatment. Thank you.
Right. And sorry, Liz, you did say that this is one of the cases where she will have the long-term HRT, yeah?
I haven't mentioned HRT, but this, in terms of if a woman has premature menopause, she obviously is not going to be able to get pregnant in terms of her own ovaries. Then she needs high dose and long-term therapy, and that is the recommendation from the global consensus on the menopause in 2013. So we would give them high dose, depending on her needs. If she's a spontaneous premature menopause, premature ovarian insufficiency as it's now called, and she doesn't want to get pregnant, there is a very, very, very low risk of spontaneous ovulation, then it's probably a good idea to put her on the pill, or you put her on cyclic hormone replacement therapy. And obviously we want her to menstruate each cycle. Thank you.
Thanks, Liz. And Sandra, your thoughts, please, for Anna?
Just very briefly, if she was going to look at naturopathic medicine for management of the menopausal symptoms, there are some limitations. If she has severe symptoms, she may not get relief, and we don't have any idea about there's unknown effects on the cardiovascular disease and bone health. If she was looking at pregnancy, I have worked collaboratively with certain fertility specialists for a 3 to 6 month treatment period to see if we can actually use a herbal ovarian stimulation. This is kind of very specialised, and I know a couple of my colleagues are listening in who have done this as well, but just to be aware that that can happen, but it's a very limited time that we would try that, and only in conjunction with a fertility specialist to see if that could occur.
Okay, great. Thanks, Sandra. And Mandy, lastly.
So the one thing that we do know is that premature menopause is responsible for higher rates of anxiety and depression. So if it is a premature menopause that is the diagnosis, I would be wanting to make sure that that was thoroughly assessed and that Anna was looked after in terms of her psychological function. I think the other thing that women who experience this in an early stage of life, particularly when it's associated with fertility, is the distress, obviously, that's going to cause. So there are 2 issues happening at the same time. Down the track a little bit, actually what's quite effective with women who have experienced a premature menopause is grief counselling because they have experienced a life event that is outside a normal life stage, and that's really difficult when you have friends who are getting pregnant and nobody really to talk to, and perhaps your mum has just gone through menopause and here you are doing the same thing. So there are a lot of issues that are very important to get some help on when a woman is diagnosed with premature menopause. So they would be some of the things that I would definitely be looking out for. Thanks.
Thanks, Mandy. Well, that just about wraps it up, and we probably haven't covered all your questions. We will try and address these once we put the webinar in our library. It will be available there by next week. So if you want to re-watch it, re-look at it, you can do that. We'll send you a link to that. And in time, in the next few weeks, we'll try and answer some of the questions that weren't covered tonight, and we'll include that in the resources there. Just a note that in the documents on the right down on the right bottom part of your screen, thank you. There are some resources that might be useful to you. There's a menopause symptom rating scale. There's a dose of HRT equivalents that may be useful for people. And there's our menopause GP tool, the Jean Hales tool, that you can order in hard copy from Jean Hales. So there's things there that might be useful to you. We'd really love it if you could stay online for a couple more minutes after, and we'd love you to give us some feedback about tonight. As I said, it's our first health professional webinar. We'd love some of you to comment and give us your evaluation. If you are wanting points or a certificate of completion, you will need to complete that evaluation. It'll pop up on the screen when we're finished. So I'd like to thank our panelists very much, and thank you all for attending, and we'll see you next time. Thank you.
Thank you.
Thank you. Good night.